Okay, I will be brief, I hope. These are my financial and research disclosures. So why do we perform imaging after surgery? Detect recurrence of the original lung cancer, detect second primaries, and these represent biologically different clinical problems. Typical surveillance schedules now are in years 0 to 3, CT scan every 6 months. After that, annual CT and PET and brain scans are no longer recommended in asymptomatic patients. And these are just some of the guideline organizations. For the most part, they're all basically the same. More frequent CT scans in the beginning, typically every 6 months, although some seem to recommend every 3 to 6 months. Some are a little less specific about it, but ultimately it's more frequent in the first 2 to 3 years, and then every year annual after that. And you can see over time it's changed. In the 90s and early 2000s, follow-up was chest x-ray based for surgery. And it was only until around 2010 that CT scans became really part of the equation to really routinely get surveillance with CT scans. And then it was around 2020 that it really became a bit more fixed, every 6 months for 2 years. And I'll just say, in the earlier session, you might have heard me mention that recurrences along the suture line were considered a death sentence. It was like stage 4 disease. And at least part of the reason for that was we used to do surveillance with chest x-rays. And so you didn't pick up the recurrences along the suture line until they were large. So those larger ones. So that's at least part of why this idea that it was really bad was because we were just doing chest x-rays at the time. That mindset has clearly changed. So when do recurrences occur? And this is kind of the key. Majority occur early after surgery. 70 to 80% of recurrences that are suture line recurrences are visible within the first 2 years, and close to 90% within 3 years if they're going to recur. So it's an early disease. After 3 years, they're uncommon, and after 5 years, they're rare. And why? Well, it's the biology, basically. The ones that recur are the bad guys. They're tumor clones already present at surgery. Cells capable of recurrence have demonstrated metastatic capability, and their growth kinetics are faster than screening, and typically they're faster than the original tumors. So recurrences are usually worse biologically than the original tumor. Second primaries, it's now been understood that the risk persists indefinitely, 1 to 2% per year. For recurrence, and it's probably higher with different tumors. The growth kinetics for these second primaries really resemble the same as traditional screen-detected tumors, and that's why we're saying screen annually in these patients, and it's sufficient to get new stage 1s. And you can see roughly these are some estimates: recurrence 60 to 120 days, typical screening. That's a little long, actually. 200 to 400 is probably a little better than that. But and if you have a non-solid tumor, there you see growth rates very variable, but sometimes 400 or more days, doubling times. And so this is just a conceptual timeline. Time of surgery, most occurrences occur within those first 3 years. They're often more aggressive biologically, and then after that, you're really looking for second primaries, which are, like any primary that you're looking for with CT. Screen at annual basis after that. Can local recurrences be treated? I think you saw in the discussion, yes, absolutely. Surgeons are very willing to go in and reoperate, completion lobectomies. The radiation oncologists, they're wanting to treat. Kelvin is ready to stick a bronchoscope in and do something with them. But I mean, the point is they're treatable. They're really treatable, and the outcomes can be very good. And we're showing there's selected reports that show good long-term survival after treatment. And again, in the old literature, it was considered, T4 disease. It's not anymore. And why recurrences matter? Well, this is where it's getting really interesting. The major trials, they're showing survival that's compatible, but they're starting to get worried, especially with the wedge resections, that there's a little more frequent recurrences now. There's suture line recurrences, and they're popping up, and we're really starting to wonder, and I can tell you that our friends in the CALGB trial, Nasser Al-Torki was just talking to me about, that he wants to now go back and get all the surgical patients that had wedges and those and see now after 10 years how many really did have recurrences. This is becoming a real serious issue that they want to know, because you get these long-term survivals, but are we getting more recurrences that are causing problems even beyond the 2 or 3 years? So I think that's a really great question that I'm hoping we get an answer to. Let's see, however, local regional recurrences and so the sublobar problem is the point here. In non-solid tumors, recurrence after resection of non-solid tumors is uncommon. It's almost rare. And it's usually local when they recur along the suture line. They frequently get other non-solids, that's for sure, these multifocal non-solids, but that's very different than the recurrences. And when the recurrences occur, which is interesting, like the case I showed, they're often solid. And nobody has very good series on this. I didn't ask Dr. Chen when he was here. He probably has more of this than anybody. But when we do see recurrences, they tend to be solid recurrences, even when the tumor initially started as non-solid, already implying that there's a much more aggressive pathology there. I don't know if Eric is here, could comment on that. Maybe you'll say something afterwards. And whether these occur, we don't know yet, those solid ones, how aggressive they are. They certainly radiologically look more aggressive. They clearly grow more rapidly. So it'll be interesting to see if their outcomes are any different. We don't know. The 3-month chest x-rays, which was, the surgeons still often do it, but they don't do it for recurrence. They do it to look for operative, things that they might have missed, a residual pneumothorax, something like that was persistent leak. They're not doing it for recurrence. They're doing it for operative. So in many places, this persistent, but after 3 months, they shouldn't be doing any more chest x-rays. The biology of non-solid tumors, again, extremely slow kinetics, excellent prognosis after resection. So the question of whether or not we should follow these the same way is really becoming a question. Why are we doing 6-month follow-ups on this group when the recurrence is, and some people are already pushing the idea that, we don't need to do a CT scan every 6 months in this group. Maybe annual is enough. And I think there's a lot of reasonableness to this consideration. Even the recurrences are probably going to be less aggressive, even though they look worse. And they're rare. They're really rare. So I think that this is something that I hope gets considered in the next ASCO guidelines. So typical recurrence pattern, when recurrence occurs, it's usually local, often along the suture line, and they often appear as solid or part solid. New non-solid lesions after surgery most represent a new primary adenocarcinoma, and multifocal adenocarcinoma development is also common. And so, final slide, 0 to 3 years is the conceptual framework, is because we're looking for recurrences which grow faster and therefore they behave differently. So the idea of doing a different screening frequency does make sense. If you know that you have a different type of cancer you're looking for, it makes sense to do a more frequent screen, which is kind of what they're doing here. So a 6-month screen. But after that, it makes sense to go back to the usual annual screen because you're looking for typical new primaries, and annual is very reasonable for that. And I think that's it. Thank you very much.